Hello, Queen Agers. Welcome, welcome, welcome to another episode of the Hack My Age podcast. I got like butterflies. So excited to share this episode with you. This is so informative. We're having Dr. Doug Lucas on again. He's been on before, and I think he's just such a great educator. So I'm excited to present him again. Before we get started, I just want to have a very, very quick thank you to those of you who've rated, reviewed, and subscribed to the podcast on Apple, Spotify, or wherever you listen to your podcast episodes. And if you haven't done that yet, please, 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 it's a small gesture that makes a huge difference to just go and give hopefully 10 stars, write a nice review. It really helps other women find this information. So please go and do that as soon as you can. I'd love you forever. And if you're just not so much of a podcast fan, but you're in here tuning anyways, don't forget that we do have YouTube. So you can watch all of these episodes on YouTube. And I think it's really cool sometimes to see what do our guests even look like. And sometimes they present things or they show their fingers up and down. It goes like this and that. And you just have no idea what they're saying if you're just listening to it. So feel free to go on YouTube. Everything is always Hack My Age and all of my social media and channels. And the last thing is go check out the menopause programs that I've been creating. There are so many great choices out there to help you biohack your menopause symptoms. This is everything I've learned in the last 15 years coaching women, everything I've learned about biohacking, my gerontology background, 4 years of podcasting with over 200 interviews, all goes into these programs and they work, they help. So please go check them out. We have very affordable ones for only $19 to full-on programs that include guidance with me as well for 4 weeks. And then you have everything in between too. So go check that out at hackmyh.com. So let's get back to Dr. Doug Lucas. The first episode, which I'm going to have a link to that episode in the show notes, go and listen to that. It's just called can you reverse osteoporosis? Yes, you can. And in that episode, we covered all the concerns about bone health and women going through menopause, the difference between osteopenia and osteoporosis. We talked about other bone diseases. We talked about why osteoporosis affects more women than men, the cultural differences in risks for osteoporosis. We talked about bone density scans and bone health scans, and there are a couple of different ones out there that you want to maybe check out instead of just the traditional DEXA. We talked about what doctors tell women about osteoporosis and what they should do, and maybe that's not such a good idea. And then he went through all the prevention protocols for osteoporosis. He talked about hormone therapy for bone health and when is it possibly too late to reverse osteoporosis. So go check out that episode. What we covered today, totally different, still bone centric, bone focused, but we talked all about testosterone and why testosterone isn't only for men and a bunch of other myths, why some doctors use DHEA instead, how to really test for testosterone. It's not just go, let's see what testosterone is. There's a whole full panel out there. He also talks about, do you need testosterone at all? And how to determine that. And he talked about the different delivery methods of testosterone, the effects of testosterone on bone, libido, and muscle, and just so chock-a-block. I mean, if you want to take a deep dive into testosterone, this is the episode for you. And we also talked about Kaatsu because he's just got into Kaatsu Bands. This is blood flow restriction. These are bands that you wear in your arms or your legs. It has a cyclical pumping up of air to partially restrict the blood flow. And then there's also a static function as well. But what this does is it increases growth hormone. And so we have more muscle. And I totally got involved with this when I did a couple of podcasts earlier with Dr. Chris Gaviglio and Stephen Munatonis from Kaatsu, because Kaatsu is a brand name. Okay. There are blood flow restriction bands out there in the market. I tried some of them. I wouldn't recommend going on to Amazon and just taking that, because there are contraindications if you do that. But Kaatsu Band is safe. They were originally made in the 1960s for cardiac rehab patients. So it's very gentle. It's even so much more tolerable than the traditional BFR bands. And my experience so far has been friggin' amazing. I have not been able to train intensively because of osteoarthritis that I'm trying to heal and get rid of. And so I was worried. I was like, oh my gosh, my bone density, my muscle mass is gonna go down. Well, duh, yeah, because you're not training like you used to. And all I can do is some boring rehab exercises, out walking, and that certainly doesn't build muscle. So I was really afraid I was gonna lose it. And I got the Kaatsu bands in March last year. So it's just been over a year. So not only did I not lose any muscle mass, I have gained it. And I just measured my muscle mass today. It's almost 39%, which is insane. It's like the highest I've ever been. It's just crazy. And if you look at my muscle mass, my body composition, you see it hasn't changed. And I still have the same look, but I see that I have even more muscle, which is crazy because I'm not able to do what I used to do. So you can see why I'm such a fan of BFR bands. And so if you want to know more, like, how does this all work? What's this all about? I've got these 2 episodes in the show notes that you should really, really listen to, because it's pretty awesome. So we did cover some of the Kaatsu bands because I was really curious what he thought about it for bone health. And he was definitely convinced about the muscle. He's still on the fence for the bone health, and it's probably because there's just not enough research on it. And he's going to be doing his own experiments with it and share it with his community. And then he'll probably get back to us. But we know that generally, the more strongly that a muscle is exercised, the stronger the bone, right? So I would kind of expect there to be better bone health. And when I looked at the research myself, specifically on Kaatsu bands, because I wanted to see did they do any, and they have some research, and I'm going to put that in the show notes too. And it's just showing not a whole lot of effect on the bone formation, but it affects the inhibition of bone resorption. And that means that the bone doesn't break down as fast. And we know that through Kaatsu training that it increases IGF-1 and growth hormones. Okay. That's why we're building muscle. And we know those 2 factors have an effect on osteoblast function and proliferation. That means bone remodeling, bone building. So, and they did have one study showing one person, like was like a, one N of 1 experiment with somebody showing great bone improvement with the Kaatsu bands, but it just more research is needed. So that's why Dr. Doug Lucas is looking into that. And yeah, just basically undeniable benefits for muscle, still learning about how that does in the bone health. If you want to get a hold of Kaatsu bands or want to learn more, listen to the podcast. Go to kaatsu.com. That's KAAA, right? TSU, Kaatsu.com. And you can use the code ZORA for 10% off. Grab those now. And I actually share a lot about muscle building, body composition with and without Kaatsu in the Biohacking Menopause membership group, right? Remember, we have this women's only support group that you're invited to be a part of. We have live Q&As every week with me and my guests from the podcast. And they're not giving lectures here. They're here to answer your questions just for you. And we're still intimate. This group is definitely worth joining to get a lot of personal attention. I can't answer every question I get on Instagram and Facebook, and it's really hard to even get to know you, but join the group, Biohacking Menopause group. And every month we have giveaways. And this month we get to win a bottle of Karen Martell's hormone facial cream called Estro 2 Rejuvenate. And we talked a lot about that, or just estrogen in general for face and skincare in another previous episode with Karen Martell that you can go backtrack and listen to that. And you can win this bottle if you join before July 1st, 2024. And you can enter in the draw. And that means you got 6 more days. That's assuming you are listening to this on a Monday, right? If it's not, then you have fewer days. And if you totally missed the deadline, because we're 2025 or something, and you're just binge listening to these episodes, then you can always grab Karen Martell hormones at karenmartell.com for 10% off with the code Zora. And have a link to that in the show notes too. And speaking of products, I would love to share that we do have a new sponsor here. It's Nebu Naturals. And this is a non-toxic makeupless makeup. I made up that word. Because everything that I've learned about Nebu, and when I go and I see other people using it, I'm like, oh my gosh, what people are saying about this is that this is like, there's serums and there's creams and there's moisturizers and things that people use on their face, and it's tinted with astaxanthin. And astaxanthin, you guys know, if you've been following me more than a minute, that I love astaxanthin for skin, and I take it as a supplement. And I had no idea you could actually put it in a skincare. And of course, that's a brilliant idea. And that's why I love Nebu. And so you can get this, and it looks like it just enhances your natural face. It's not makeup. It's just serums and nourishment for your face. And I met the founder, Nikki Burns, in our Facebook group, and she threw some of these products at me, and I was like, okay. And I just tried them out for a year now. My daughter has stolen them. She absolutely loves it. And there's this one called Glow to Sleep, and it just makes you fall asleep real fast because it's got this lavender in it too. So go check it out. Nebu, N-I-B-U, Naturals, with an S at the end.com. I have a link in the show notes. You can get a generous 20% off with the code Zora, Z-O-R-A. So go check it out. And what I really love about Nikki Burns is she created this stuff because she had her own issues, health issues, and reactions to toxic skincare. So that's why she made this herself. And yeah, no, she's just such a wonderful person. I met her in person, and I'm very picky about who I choose to sponsor on the podcast. And she's just one of those. Got integrity, won't cut corners. And actually, her skincare is really affordable. So go check that out. Now let's get back to Dr. Doug Lucas. I keep getting distracted. So I really loved how Dr. Doug Lucas taught us so many things in that first episode. I just had to have him on again. And he has a great voice. It's just the way he talks, and his teaching style is so spot on. And it's just something that, speaks in a way that we can all understand. And he is a double board certified physician. This is like a proper doctor. And he did his foundational training at Stanford University, and then started a traditional orthopedic surgery practice in Durango, Colorado. But he saw that after just about 5 years in this traditional medical model that most doctors go down, he found out that he needed to get a second fellowship and board certification in anti-aging and metabolic medicine. How cool is that? So, he decided to do this so he can just take a different approach to treating people's problems, right? And that's why he started Optimal Human Health. And that's a website and his own practice. And I'll have that link in the show notes. And this work, when he started working as a functional medicine doctor, he just got thrown into the metabolic health, hormone health, and now just absolutely focused on bone health, because a lot of his patients are women, and they were having problems with osteoporosis or osteopenia and freaking out. And he's been able to help them and reverse it. So he just put together all of his knowledge, and he brought on more experts into his team and created this optimal bone health company. And so go check him out. And actually, if you go look at his, quote unquote, meet the team page, it's such a female-centric company. He's got 12 women on his team, and they're 3 guys. So he knows his bone health, and he understands female patients really, really well. So now that he's totally focused on bones, he really believes that osteoporosis is a disease that just needs a comprehensive approach to understand why we are losing bone and then just reverse those causes, right? It's totally doable. Makes total sense. So before we jump in and meet Dr. Doug Lucas, I have to read the fancy disclaimer here. All the information discussed is for informational purposes only. No patient relationship is formed, and this podcast and any material within it is not and should not substitute for medical care. Go to your own medical doctor or get in touch with Dr. Doug Lucas if you need help. So let's get started and enjoy the show. Okay, well, welcome, Dr. Doug Lucas. I'm so happy to have you on again for part 2.
Hi, Zora. So happy to be here. And the communication that we've had since the first one to now has just really reinforced my desire to help you build this community, because you are talking about things that I think are so important to this audience.
Oh, thank you. Yeah, no, it's bone health is so important to women going through the menopause transition. And we took a really deep dive into that when we had the first episode. And I'll have a link to the show in the show notes for that fabulous episode. So for sure, go there. But today we're going to take a deep dive into testosterone and what a woman in menopause in this transition really needs to know about it. Because I think we had a conversation, I don't remember when, and you were saying, yeah, you've been really taking a deep dive into this, and there's so much that you have to share. And I'm super excited to let the women know, because testosterone kind of gets a back seat to estrogen, progesterone when we're talking about hormone therapy. So let's start there, straight with testosterone, and maybe some myths, what does it do, and some myths around, what it does actually do and what it doesn't.
Yeah, man, it's such a great topic. So I think when we were talking about it, I was in the midst of writing this book, which I'm now like rewriting for the, 4th time. But when I was in the midst of writing the section on testosterone, I kept coming across research that just continued to blow my mind and change the way that I looked at really bioidentical hormones for women. And so I think let's talk about probably the biggest myth, which is that testosterone is a man's sex hormone. Right. And we think testosterone, I mean, I picture dudes in the gym doing injections and getting huge and getting angry. And, that's just my biased perspective. When I talk to women about it, they have that same thing where they're like, it's muscle, it's anger, it's like all these things that were portrayed in whatever, movies and social media, whatever. But one of the things that really blew my mind when I was doing research for the book is there's a study that showed me something that I can't believe I hadn't picked up before, because this was I don't know, not even a year ago. And it was a study looking at the levels of sex hormones, comparing specifically estradiol or estrogen and testosterone. And when you adjust for units, and so in the US, they're measured in different units. When you adjust for units, a woman actually has more testosterone by volume by 5 to 10x than do they have estrogen.
Yeah.
Right. And so
insane.
it's like, well, wait, not only is testosterone probably important, but a woman has more testosterone than she does estradiol at any point in her life. So why is it then that when we talk about especially bioidentical hormone replacement, why don't we include the conversation around testosterone? So that really sent me down this path of thinking why don't we do this? What are the what's the potential benefit, and just on and on and on. So I got really, really deep into testosterone, and I look forward to sharing all of that because it's just fascinating.
So you're absolutely right. The myth that it's a man's hormone, we got to break that one. And as far as I understand too, I mean, the women who are in the menopause and the hormone space and learning more about it and learning more about testosterone, the two things that come up that are important for us is the libido. If you've got low libido, we're like, okay, well, let's jack it up with some testosterone, or muscle mass, because it's so hard to build the muscle mass without the estrogen. But testosterone also plays a role, and as well as the bone health. And since you're the bone guy, I'd love for you to talk a little bit about those three, and really how important is it? Is it just testosterone, or because we do know estradiol plays a role, and other hormones in some of these things, as well as the motivation as well to get to the gym and do things. There's a whole can of worms here. Maybe you can pick it
Yeah.
apart.
So let me yeah, I'll edge into this from the bone health side. So when I was doing the research on this, I always pay attention to bone health literature because it's just near and dear to my heart. And one of the things that was so compelling to me is that even though, like you said, for women, most of the research is on libido, sexual function, this thing called hypoactive sexual desire disorder, HSDD, which we need to talk about a little bit around like why people don't talk about testosterone. But most of the research is on that topic. However, there is some research specifically on women and testosterone looking at side effects, looking at dosing, and then also the impact on libido, cognitive function, attitude, they call them psychiatric disorders in the papers, unfortunately, but mood, right? So like what are the mood changes that go along with it? So from a bone health perspective, there are only a couple of studies, but you can clearly see benefit from either testosterone alone or testosterone in conjunction with estradiol and progesterone if they had a uterus. And so you can get a sense that testosterone is independently related to bone health. So when I'm creating a program specific for women and their bones, we want to look at the levels and see, is a postmenopausal woman actually deficient in testosterone, either based off of symptoms or off of blood biomarkers? Because unlike estrogen and progesterone, which of course have dropped off in production, testosterone doesn't necessarily drop off. And this is a big kind of challenge around, who needs testosterone and who doesn't, because it's possible for a woman with good adrenal function, which is, which is where we make our cortisol, our DHEA. If you have good precursors to testosterone, you don't actually need or would benefit from testosterone. So for doctors that say, oh, well, not all women need testosterone, that's absolutely true because you don't see a drop off in testosterone as predictably at menopause as you do estrogen and progesterone. Does that make sense?
Yeah, it does. And actually, I learned from Dr. David Rosensweet when I did this Institute of Bioidentical Medicine program with him. He talked about testosterone, and very often women in their 50s, when they are really deep in the perimenopause symptoms, very often testosterone can stay elevated for a good 3-4 years. But he says eventually it's gonna go down. And I think he's talking about when you hit your 60s and 70s, then it really
True.
takes a time. And he was pretty certain like it will go.
Yeah.
Whereas when you're in your 50s, you can still find women, a lot of women producing a lot of testosterone, and perhaps they
Right.
don't need it. Is that true?
But yeah, absolutely. And we see that, and we have, a unique population because most of our patients have osteoporosis and therefore they also have sarcopenia or loss of muscle mass. And in that population of patients, they tend to have a lot of stress, either related to their diagnoses or related to other things. And I think those two things go hand in hand often, is stress, anxiety, overproduction of cortisol. So in those patients, we don't see it very often. But for our patients that are not in that group or for whatever reason don't have a cortisol issue, which aren't very many, but they are still making adequate testosterone. And that's why I think it's so important not to just jump on a testosterone replacement without really knowing and talking to someone who understands like what symptoms are more likely related to testosterone than not. There's always overlap, but there's a lot of nuance there.
So what are the symptoms other than what we generally know as a low libido or difficulty building
Sure.
muscle mass?
Yeah, and so it's funny with low libido, like I've been talking to a lot of practitioners doing research and just trying to get a sense of how to best manage patients. And there are a number of practitioners, especially in the physiologic HRT space, who will see tremendous improvement in libido with estrogen alone, but estrogen at higher doses than we would generally do in the traditional medical model. So I don't know that it's always testosterone with libido, but it's very commonly seen that low testosterone equals low libido. True in both men and women, right? So it's pretty consistent. But outside of libido, our patients are most likely complaining about fatigue, brain fog, and these are symptoms that sort of cross over a lot of things, right? But fatigue, brain fog, difficulty sleeping, difficulty maintaining muscle mass or losing muscle mass, changes in body composition outside of what you would expect to see with estrogen deficiency, or if they're on estrogen and they still can't maintain that body composition that they're looking for. We also find that it's kind of hard to describe, but like this feeling of vitality, vigor, just the go-gettedness, if that's a word, but that idea of like wanting to go to the gym and work out, wanting to pursue this dream or whatever it is, that feeling of vitality is related to testosterone. And so we ask these sort of very specific questions around that to try to understand, is this person likely deficient in testosterone depending, we look at their biomarkers, but testosterone and biomarker is not that easy to really understand as a black and white biomarker because there's a cellular level, there's a receptor level. And so we have to put all that whole big picture together to understand, is this person potentially going to benefit from testosterone replacement?
I generally like to recommend to the women that I'm working with is to get the estrogen and the progesterone on point and then add in the testosterone, because what I've been seeing is that yes, like you mentioned it, you may be able to mitigate some of these symptoms that cross over. Could be testosterone, could not, but also the estrogens are converting into testosterone or vice versa. And so that's something that I think I would like my women to take an approach,
Mhm.
or do you just throw it all out at the same time?
Yeah, we're in this transition phase right now. So when I was trained in this, we started all at the same time. And the more I read into the true physiology, so there's sort of like the replacement, the technical stuff that we learn. But as you get into like the physiology, the health optimization, the longevity, the anti-aging, the epigenetic side, you've got to start to get a sense that the receptors play such a big deal here. The genes play such a big role here. And when you look at what happens when you give testosterone and estrogen together, they kind of overlap in their receptors. And
Mm.
so there's some thought that, well, if you give them together, then you're not going to really adequately upregulate the estrogen receptors. You're not going to be able to stimulate them adequately, versus if you were to start with estrogen, withhold testosterone for a while, and then sort of figure out where you are, let the estrogen receptors do their thing, and then add testosterone later. So it does make sense to me, and we're in the middle of transitioning. I have a number of providers now in my practice, so for us to make a move like that, we would all have to agree. So we are sort of like talking about it on a regular basis. I'll put it that way.
Yeah, exactly. So what about, in also with the training I've done, we were taught to, again, take the estrogen, progesterone first, but some women with low testosterone get their doctors to use DHEA.
Mhm.
So what do you think about this approach, and how does that work?
Yeah, I was very heavy on DHEA out of the gate because I was more concerned about the side effects of testosterone. When I was new into replacing testosterone, we as a physician, we're taught like it's dangerous, it has side effects, and it's scary because it's a controlled substance, and the DEA is going to come down on me, and I'm going to get hauled off and handcuffed for prescribing it. Um, as I've gotten more comfortable in the space, I've started to use both. But then I run into this issue where they both have the potential of the side effects around androgens, right? Because they're both androgen producing. So that those androgen side effects of oily skin, acne, potentially hair loss and hair growth, women don't like those things, I hear. So we want to mitigate that. So I've sort of swung from using DHEA more to using testosterone and withholding DHEA. Now we're kind of back to using both, but at lower doses, and then, kind of like trying to figure it out for each woman. So again, I think there's so much nuance as to who's going to benefit from what. DHEA is, I don't want to say it's safer. It's just easier, right? It's over the counter. You can dose it low, you can ramp it up, there's cognitive benefit. So there's some value in using DHEA alone, particularly in a woman who's not interested or sees side effects with testosterone that we don't get with DHEA. But I think that testosterone has better research to support its impact on bone and muscle. So that's why I tend to lean on testosterone still, because I really want to see in my patient population improvements in bone and muscle, because that's what their primary problem is.
Interesting. It'll be interesting to see if any research comes out on bone health and DHEA and all this stuff, because yeah, doctors do tend to use both or have a preference for one or the other. And it's interesting how, yeah, you explained what happened in your practice, and how cool. Yeah, the research on testosterone is showing really, really great benefits. So let's bring that conversation at least into the puzzle. But I think what I understand is that if you are taking testosterone, you've got to test to see where you're at. Kind of like, do you take vitamin D? Well, let's see. Do you need it? But
Mhm.
what it's not just going to a lab and saying, hey, test my testosterone, and you just have this one total testosterone marker.
Right.
Let's talk about all the full panel and all the
Yeah.
blood tests that you would need to understand a woman's testosterone and how much she's actually using, and if she would need it.
Yeah. So when we start, we are always getting, and I've heard sort of some controversy around this and different providers and influencers, but I always want to know where a woman is before we start anything. Even though if she's postmenopausal, I can anticipate what her estrogen and progesterone levels are, but I'd hate to be surprised, right? And so I want to get estradiol in serum, so in blood. I want to get progesterone in blood, which is kind of that's an interesting topic on its own. And then I want to get total testosterone, free testosterone, and then we also want to test SHBG, which stands for sex hormone binding globulin. We don't always test that last one because there's some way to calculate around it. But the reason for understanding all of those things is that total testosterone, we see widely variable in what I would consider a therapeutic dose, meaning where women actually feel better. We see some women that feel great with a total testosterone of 30. We see some women that need a total testosterone of 150 to 200, right? And so if you're just going off of the biomarker and you're saying, well, I just want to get you to 30, then you're going to miss the boat on some women. And one of the biggest reasons why you're going to miss it is because they have a higher level of this SHBG thing. SHBG is going to grab the total testosterone, and it's not going to allow a lot of free testosterone out. And so if you have high amounts of SHBG, you're going to need more total testosterone to have adequate free testosterone. I've seen women with a total testosterone of 150 with a free testosterone of less than 1, right?
Wow.
And so then you're like, oh, like, do I give you more? Like, are you having any side effects? And this is where there's so much nuance in why I'm such a fan of using, daily dosing. We'll talk about how we do that, but daily dosing, I don't like pellets. I want to know how to manipulate your doses every day if needed. Prevent side effects and measuring as regularly as we need to. Now, it doesn't necessarily have to be that often, depending on how you're doing, but as regularly as we need to, especially as we're figuring out what that right dose is for you.
I think I asked you in our live Q&A with the Biohacking Menopause membership group when you had that interview, speaking to our women, and I can't remember what you said, but we talked a little bit about the free free testosterone and bioavailable testosterone. Can you
Yeah.
talk a little bit about what are those differences, and do you also look at that in addition to the total testosterone and
So
SHBG?
yeah, bioavailable is just another way to calculate free. And so I actually forget what's included in there, but it's a bigger number than free because it includes testosterone that's weakly bound to something. Maybe it's albumin. I don't remember exactly what it is, but it's just another way to look at testosterone that is not bound to SHBG. But there are other things that testosterone can be bound to. So it's just another way to look at it. So you could use bioavailable depending on what labs you have available to you. The question is, when you look at the reference range, what do you do with that reference range? So for us, especially in the postmenopausal women, the reference range for free testosterone in postmenopausal women, I forget what the actual upper end is from LabCorp, but it's extremely low, right? And it goes to 0 because plenty of women have no testosterone. And so you can't look at a statistical average, which is what most reference ranges are, and say, oh, this is what I want to aim for. Because if that were true, then aiming for 0 would make sense, and it doesn't. So, so you have to understand, like, what are the optimal ranges? And that's, again, having a discussion with somebody who is deep in this, who's doing it a lot, to say, oh, this is the range that I see my patients doing well in. Literature can help you to some extent, but probably not with testosterone in women.
What's the albumin piece? Because in Europe, very often when we're testing for testosterone, they include that in their
Mhm.
their blood
Yeah,
work.
it's another protein. So like if SHBG is a protein, albumin's a protein, and sex hormones combine to it. Because the sex hormones aren't water soluble, so they can't float around free for very long, right? So that's why you have such little amount of free testosterone and you have so much more total testosterone. It has to be bound to something to travel around. So it can bind to albumin as well. It's just another big protein in blood.
So if that's very high, then that means that there's not enough available testosterone. And so you got to figure out how to get the albumin or the SHBG down, right?
Well,
Or
yeah,
to free up
may,
the testosterone? No?
maybe, yeah. So it's hard to manipulate SHBG, and I actually wouldn't want to bring albumin down. I mean, in my training, I think of albumin more as like a marker of protein metabolism, and like, do you have adequate protein in your diet? There's probably more to it than that, but that's how I've always used it. So I wouldn't want to manipulate albumin, and I haven't found trying to manipulate SHBG to be very effective.
I don't remember where I heard it from, but I learned that taking birth control in your youth for, I don't know,
Drives
for
it
no,
up.
it's more like 10 or 20 years,
Right.
that may raise your SHBG and it may
Yeah.
never, ever come down, even when you go off the
I've seen
hormone,
it come,
the
I've
birth
seen it
control?
come down, but it seems to be very slow. And that's why, what I mean, I don't like it as a tool to manipulate because it would take so long to get there. And it's not really clear what is the most impactful lever there. For us, we look at it more of like a marker of stress. So for people that have very high SHBG, typically those are people that are stressed out. And this was true for me. My SHBG, when I started on testosterone therapy like 4 or 5 years ago, I mean, it was like over 100, which is very, very high. And so I kind of looked at that and I was like, oh, that's weird. I wonder why, right? I didn't know then. And now as I've worked with all of these patients, both men and women, and I see very consistently people that have a lot of stress have very high SHBG. And so I think working on the adrenal function, your stress, your lifestyle, all of those things will help to bring down SHBG, but it does take time. I actually just had mine retested this like 2 weeks ago, and I think it was like 27. So,
Oh,
like, woohoo, I did it, 5 years later. But it's another reason why you do have to continue to monitor your labs too, because if I was taking the same dose of testosterone then that I was now, I'd be way overdosed
yeah.
because you need more. And that's how we look at that, is to say, well, if you have high SHBG, high albumin, and you still have low free or low bioavailable testosterone, then you need to increase your dose, and you don't need to necessarily worry about side effects because it's the free that's going to impact your cells more. Obviously, we still want to ask, and that's why again I just don't drive it up willy-nilly. We ask, we go up slowly, we continue to monitor.
Let's talk about some of the side effects when you overdose testosterone in women. What do you what do you see happening?
Yeah, I mean the biggest one that women care about that they report to me anyway is hair loss. This is already a problem, especially in our patient population. They tend to have thyroid dysfunction. There's lots of reasons why hair falls out as we age. Loss of sex hormones is one of them. And so adding testosterone, which could potentially make that worse, is really scary for a lot of women. And I totally get that. I don't, for those that are listening to this, I don't have a lot of hair, so I've sort of accepted this. Fortunately, as a guy with a well-shaped skull, this works for me. But I totally understand that it's a big deal to lose hair. And so we always want to be very careful of that. What's interesting, though, is that when you look at the research, even the quote unquote high dose, which I don't think they really were that high, but the theoretical high dose testosterone dosing in the research compared to placebo, there was a very, very small increase in the risk of hair loss. But what's really interesting is it was frequently complained about in both the intervention group and the placebo group. And so I think I'm trying to remember the exact study, but there was a study that had low, medium, and high doses. And I want to say that the high dose group of testosterone wasn't even statistically significant compared to placebo because so many women on placebo complained about hair loss. So it just shows that it's a common complaint. We see it all the time. I'm not saying that it's not real. It's like it's all in their head. Like, no, I think that it's real because I've certainly seen it. Where we see it and it's really bad is women who have gone on pellet therapy and have been put on a very high dose that they didn't tolerate, and then you can't get it out. And that's a really dangerous thing because then you're going to lose hair for the next 3 to 6 months, potentially at a really high rate. And so we've seen some really atrocious hair loss, and it's really been troublesome for some women. So that's why I don't like pellet therapy for the side effect reason. The way we dose it, we use a cream. You apply it either once or twice a day. And if you start to see side effects, you can, of course, back down or back off, right? It's just that simple. And then we figure out, like, is there anything else going on? Is there any other reason why you could be losing hair? And the answer is always, there's other reasons why you could be losing hair. And we try to work that out. But in the meantime, we're also then working on your dose of estrogen and your dose of progesterone. And, maybe we could potentially use DHEA, of course, because they're different pathways. So there's just all these different ways to manipulate. But hair loss is by far the biggest one. Hair growth, we see a little bit of that. People will complain like, oh, I've got a few more whiskers on my chin than I've had before. Doesn't seem to be as much of an issue for women. I think that if they're doing well on testosterone and they feel so good, that's a trade-off they're willing to make, as long as they're not like growing a beard.
And if you put it on the back of your knees, you got a bush growing in the back of the knees that scared me so bad when I first found it. I was like, what in the world? So I was taught then, well, you just put it on your abdomen where there are no hair follicles, at least for females. Right. And
Yeah.
I swapped because I was horrified when I first saw that hair growth. I mean, thank God it wasn't on my chin or my face, but
Right.
you'll
Yeah. Don't
see
put
it.
it on
And
your
this is
face.
not very high doses of testosterone. Sorry, I
whatever's
had to
normal.
mention
You're
that.
using high doses. No, yeah, I agree. And so when I was trained, we were trained to either put it on inner thigh, somewhere that you potentially already shaving, or use it actually on your external labia. So then an area that not a lot of people are seeing probably,
Mhm.
or an area that already has hair or doesn't have hair, either way,
Mhm.
right? And so that's the way I was trained, although I find most women would prefer to use like their wrist, their forearm, belly. I haven't actually used belly, but you're right. I guess there are not a lot of hair follicles there.
Mhm.
Back of the knees, something that we recommend as well. But it just depends. Also, rotating can help to diminish that hair growth. But you're right. I have heard that and had some very distressed women.
What
Dark,
about
dark
w-
hair.
yeah, so when I've heard some women doing very high dose testosterone and having their kind of growing a penis, like the
Yeah,
engorged
clitoral
the
enlargement.
clitoral engorgement or
Yeah,
enlargement, and
yeah,
that was I mean I've seen it myself, but I've heard about it, and it kind of scares a lot of women. They're loving the libido. They're like, this is fabulous. Some women are like, it's a little bit too much. I even just when I wear my underwear, it's like I get excited, so I gotta like
right,
take down the dose. So these are just some
right.
of the things that I've been hearing in our community, but I'm not sure how often are you seeing patients like that where they
Yeah,
kind
I
of
mean,
go a little bit over the edge.
I want to say our doses. I don't want to. They're definitely not low, right? Because we're going for a physiologic dose. So we're definitely not using low dose, but I don't hear those side effects. I've seen it in the literature. I've seen one report of clitoral enlargement, but they didn't examine the clitoris, right? So they're like, it was reported.
Mhm.
But outside of that, I've never seen it in the literature as a side effect. So again, this is something I believe it probably exists. There's a lot of variation, especially in female anatomy. Like, could it be more engorged? Yeah, I'm sure, right? Is it actually getting bigger? I don't know. But I would imagine this would be at a bigger dose, right? If you're actually masculinizing a woman, that's got to be a big dose of androgen. Same thing with the hoarse throat, like the deepening of the voice. Like if you're actually changing the anatomy of your vocal cords, I feel like that would have to be a massive dose. Again, in the literature, it never comes up. I think there was maybe one report of a woman who noticed a more hoarse voice, and I'm using quotes there for those that
Yeah.
are listening. And I've not seen that in any of our patients that they've reported.
That's good. 'Cause these are women who I've heard are actually injecting testosterone. So the
Yeah.
creams were not working, and then they just move on to the injectables. And so then that's where you can get, yeah, kind of hairy.
Well, I think you have to be careful with injectables. And I have some women that are on injectables, and I use injectables. But the thing about injectables that's so easy to make mistakes with is dosing,
Mhm.
right? So we have a lower strength that we use in women, and because really we use 100 milligram per ml, and then you're using zero point 0.1 ml, which is a very, very small amount. So you could imagine the potential mistakes in dosing is where if you use like say 1 ml versus zero point 0.1 ml, like that's a 10x shift, right? Or if someone sends you, because the 100 milligram per ml is not that common, let's say someone accidentally sends you 200 milligrams per ml, right? So then you're doubling your dose. And that's already, even zero point 0.1 ml at 100 milligrams per ml is it's a small volume, but a high dose. So it's tough to do injection in women unless you were to be able to compound it at a different strength. But even then, it's so easy to make errors that way.
Yeah, I think that's kind of like the last resort. There was a gosh, I totally forgot what the question I was going to have, but there I'm wondering I'm wondering then with with testosterone um the the pellets are kind of the same, at least the feedback that I'm getting. There's some women I speak to or I see on our social media channels, and they're loving the pellets. And I'm
Sure.
like, I guess there is a community out there, but I'm like you, where I just don't like the idea that you can't titrate, you can't change the dosage. Like you're really stuck there. And I think they're
Stuck.
pretty expensive in that sense too, aren't they?
Yeah,
Much
I mean,
more.
there's convenience to that, right? So like, let's say a pellet therapy is going to last for 3 months. You're like, cool, man, I did this back in June. I don't need to do it again, right? For 3 months. Like, this is easy. But my concern is the side effect thing, like I said. There is an expense, but you could argue, time, cost of money. So whatever, maybe the expense is worth it. The other thing that I don't like about pellet therapy is that most pellet doctors that I've talked to are only doing testosterone therapy, and they're not adding in estrogen and progesterone with the idea that, hey, if it's the primary sex hormone in women by volume, what do they need estrogen for? In fact, I had a potential business partner that we were considering building a company, and he had like his his philosophy around hormones for women, even postmenopausal women, was testosterone only. It's all they need. And I'm like, I can't, like, that doesn't make sense. Like, that's not, there's a reason why estrogen and progesterone exist in a premenopausal woman. In a postmenopausal woman, I don't think you can say that they're not necessary, or they wouldn't provide benefit, even better, right? And so I just worry about using testosterone to then aromatize or convert to estrogen as a tool for estrogen, thinking that you're potentially avoiding the risks of giving estrogen. Again, that doesn't make sense to me. If your goal is to drive up estrogen, and then it doesn't matter if it comes from outside or from inside, the risk is the risk either way, whatever the risk is, which is another conversation. So I don't like it. If people are having a good experience, that's okay. I would still want to know, like, where are you at your peak? You know, where are you at your trough? Do you really feel good for that whole 3 months? Because you're going to see a massive rise and fall. I would want to keep it more consistent. Let's keep it physiologic. That's why I started dosing myself with testosterone with daily injection rather than like once a week or twice a week or whatever, because I want that natural physiologic rise and fall. Testosterone is supposed to rise in the morning and fall in the evening. It's part of our circadian rhythm. You know, so pellets just very, very unnatural.
I agree. I'm wondering about the side effects that women do feel, and it's great that we can just lower the dosage or stop your testosterone and get back to normal. But I've heard that there's some irreversible damage that can be done. And so what are those damages, and how much do you really have to be taking for it to be irreversible?
The one I worry about the most would be hair loss, particularly around the temporal zone. So for those that can't see me, you probably know where your temples are, right? Like where you get a temple headache. But that temporal hair loss is reported to not return. I've only seen that maybe in 1 or 2 patients, and for them it has come back. So I'm sure it's possible that you could lose it and not come back, but that does concern me. So we'll tell patients, look, if you're losing hair, let us know. When they report to us, hey, I'm losing hair, we'll say, you know, pull your hair back if you have long hair. Where are you losing it from? If it's your whole head, it's actually probably not coming from your testosterone. If it's coming from the temples, let's back off, right? Let's take a pause. Let's see if we can get this to grow back. You can use different tools for that, but that's the big thing that we worry about. And again, pretty rare. And then other structural things, like you mentioned, clitoral enlargement and hoarsening of the voice or deepening of the voice. Like if those are actual structural changes, I don't know that they would go away. You would think that they would, but they're not well studied, so it's hard to know.
What kind of levels do you see in the serum, or do you think a woman would have to have in her serum for you think to do some of this irreversible damage?
It doesn't need to be high, and this is where that individual variation is a big deal. So I've seen women that have reported hair loss with not particularly high levels. When that happens, though, you have to raise the question like, well, is this placebo? Is this from something else? Right? So I've had women who've, and it's not funny, but they reported hair loss, and you look at their labs and you're like, your testosterone is actually lower now than it was before. You know, like, I don't think it's from the testosterone, but you still have to go down the pathway because maybe they're just super sensitive. Their receptors are sensitive. I mean, whatever, right? There's so much variation when it comes to sex hormone, but definitely would want to look for other potential causes.
I want to ask you about prolactin for hypoactive sexual disorder. I've read that some doctors will test your prolactin, and I don't know if it's too high or too low. Then that means it may not be the testosterone related, but it could be related to a tumor in your brain or just having the low prolactin or high prolactin. I don't remember what it was. Did you know
Yeah,
anything
we
about
actually
this?
don't check prolactin in women. I do check it in men, and it's funny. I've never actually looked at the incidence of prolactinoma, or like a tumor in the brain that makes prolactin. I've never looked at that in women. It would be an interesting research, but it's never been in I've done training through, I don't know how many different groups. Nobody's ever talked about it. So it's certainly not standard of care to check prolactin in women. But we know in men, if they have high levels of prolactin, they'll have low levels of testosterone. So when we see a guy, especially, I just had a case where it was a younger guy, my age, I'll call him younger, a younger guy, my age, who, I'm 46, by the way. So a younger guy my age who had very low testosterone, like in the 200s as a man, which is truly hypogonadal low testosterone, and very symptomatic. And then when I looked at his prolactin, it was high. And I was like, uh-oh, like, let's repeat this, but we might need to send you to endo. You might need an MRI of your brain before we start testosterone. Because what you don't want to do is just start testosterone and just forget about this brain tumor. That's not something you want to miss. but I've never heard it described in women. So that's an interesting idea. If prolactin goes up, testosterone will go down. So I would assume that would be the same in women as in men. When it
And
comes
these
to
tumors
HSD,
are actually are usually benign, as I
correct, yeah,
understood.
correct.
So
But you
not to
still
freak out.
wouldn't want to miss a pituitary or
Yeah.
anyway. But the HSDD diagnosis, so we kind of described this earlier. So hypoactive sexual desire disorder. So this drives me nuts, and I've done whole talks on this, and it's really interesting when we look at aging, symptoms of aging in men. If you consider aging a disease, which you and I are probably on the same boat there. If you consider aging a disease, you look at the symptoms of aging in men, and there's clear, studies that have looked at this, and there's whole things that describe it. But there's a scale like this. There's a scale called the Aging Male Symptom Scale, I think the AMS. So many of those things are related to libido, right? And when you look at like libido, like erectile function, sexual function, like all of those things. And then when you look at women and you look at symptoms of aging, a lot of times they're going to talk about menopause and, vasomotor symptoms, urinary tract symptoms. But nowhere on there is libido, right? Nowhere on there is sexual function, ability to orgasm, et cetera. So for women, you have to, if you're having those symptoms, you have to get diagnosed with a psychiatric disorder. For men, you have to just be diagnosed with aging, right?
Crazy.
And it's the same thing. Why is it okay for men to always have a libido and want to have sex for the rest of their life? But for women, we're like, no, like you're crazy. Literally, I'm calling you crazy if you have a low libido, you have a psychiatric disorder. That just drives me bonkers. So anyway, I think that is one of the reasons why testosterone is poorly studied, because women don't want to talk about it. Doctors don't want to bring it up. They don't want to use the diagnosis, and there's no commercial product to use, even if they wanted to. Yeah. So it's like, it just is something that our culture and society have just wiped off the map. We don't talk about sex in women over the age of 30. Like it only matters. That's why you see like female movie stars with older male movie stars. The females are under 30 and the men are 70, right? You're like Harrison Ford with, whatever attractive 20-something woman. It's just our culture. It's our society, and it's maddening. So that HSDD diagnosis, I think, has really messed up the progression of studying testosterone for women, particularly in perimenopause and menopause, because they've just been forgotten about.
That has to change. I mean, we know through the Harvard study of adult development that I always quote that the biggest factor that will help us be happier longer, living longer lives are strong bonds, strong relationships. And right. I mean, not that it only has to be with the opposite sex or a sexual partner, but yeah, that counts. I mean, so if our partner's got a high libido and we don't, how is that relationship going to work out? And
Totally.
so I think it's something that really shouldn't be ignored. And I've really got to find more women to interview about low libido. I'm so on this track. I think it's really important. And I understand women in menopause, you're like, that's like the last thing on my mind. I'm not sleeping well and my vagina's all dry and I just not into it right now. So you always push that aside. But I always want women to just take a second look. I mean, if you're fine and your partner's fine and you're happy with low libido, that's okay. That's none of my business. But right. But if it is, like, don't just ignore it. I think it's really part of our relationships, which me as a gerontologist, I'm like, well, that's important for aging and longevity. Then sure. We have to take consideration our desire for sex and our relationships. And this is intimacy, it doesn't have to, always be, penetration and all this thing that we have this image of. It's intimacy, right. Intimacy that really counts.
That's exactly what I was going to say. I find that it's the intimacy that matters. And again, it's not like actual sex, actual, penetration, male, like that's a part of it, whatever that relationship is. But because I end up having these conversations with my patients, and it's the intimacy that they miss, right? And that disconnect between men and women, especially as women get into perimenopause and menopause, it gets wider and wider, right? I think it might always exist for most couples, but it gets wider and wider, and that becomes a big issue, and you lose that intimacy because men, I can speak, personally, and from all the men that I talk to in a bunch of men's groups, we are terrible about telling women, especially our partners, what we want, what we need. right? And so then you create this division and you lose the intimacy. And that is such a huge part of creating a relationship and keeping it strong over time. I heard a quote the other day. This actually came from Mark Sisson, who's somebody I've followed for a
Oh,
long
love
time.
him.
Actually,
Yeah.
my wife was interviewing him for her podcast, and it was so great. He was talking about, kind of one of his secrets to longevity, because he's getting older and he looks amazing and he has such a great following. And he was like, I always look at three things. He was like, if I'm feeling happy, horny, and hungry, then I'm on the right track, right? And you're
Yeah.
like, oh, that's
That's
fantastic. How
funny.
simple, right? Happy, horny, and hungry. Because
Yeah.
then everything is online, right? Like everything is working well for the
Yeah.
most part. So
Yeah.
I thought it was a really good way to look at it.
Oh, that's hilarious. That's really funny. But yeah, these are, but we also want the partner to feel the same way, because if the partner isn't, then it's just not gonna connect and click. So,
Right.
but happiness to me, yeah, I mean, that's just whatever it is. If you're happy, great. I mean, don't change a thing. So
Right.
we only have like a few minutes left and I have to let you go, but um the preference, I wanted to cover quickly your preference for delivery methods, and I'm assuming this is a cream or a gel
Yeah.
or something, right?
Yeah, so we're using pretty much all compounded products. It gets us out of the commercial system. It gets us out of the insurance system, which drives dosing, it drives products. So I just want to be removed from all of it. So we use creams for both estradiol and testosterone. We dose them separately. So I want to be able to manipulate the dose of each, so I don't combine them out of the gate. Probably we'll starting testosterone later, but that's another reason to separate them. So testosterone cream. If a woman doesn't respond to the cream, or some women just have like armored skin, it just like, does not penetrate. And so if that's the case, we consider injection. And because the volume is so small, even though testosterone is designed for an intramuscular injection, and that's what I do every morning, because the dose is so small, you can get away with a sub-Q injection most times. So 27 gauge, small needle, sub-Q injection, not as painful as an intramuscular injection. So it's not terrible. That would be kind of option B for us. For estradiol, though, we're always topical, pretty much always cream. I'm open to a patch if someone really has to use insurance for a potential reason, but we are not going to likely to be able to get the same systemic levels of estradiol through a patch. Progesterone for us always comes through either micronized capsule, or I'm entertaining the idea of higher dose creams. I'm learning. I'm open to this idea when it comes to like physiologic dosing and how do I actually get enough progesterone in there to balance higher levels of estradiol. That would likely need to come through a cream.
Interesting you say cream. I would guess maybe the oral would be able to get
You
faster.
run you run into max dosing, so you hit a ceiling with the amount that you can tolerate, because the metabolite of progesterone is a GABA agonist, right? So it's not sedative, but it's relaxing. You'll run into a cap as to how much you can actually consume orally before you get the side effects of waking up feeling hungover. So depending on how high you want to drive estradiol, if you want to drive it higher than you can then counter with an oral progesterone, then you would have to switch to another route. I was trained not to use cream because it doesn't absorb well, but I think there's also challenges of how are you measuring it? Is it going to show up in blood? It's a whole nother thing.
We're all so bio-individual. It's just crazy. So that's why we need a good doctor like you to help us figure this all out and understand, because it's not a one size fits all. One last question I think is really interesting is, what if a woman who has low testosterone, you've done her blood work, but she's resistant to taking testosterone or even hormones that as it is. So are there any other approaches that she can take to improve her testosterone levels and those symptoms of insufficiency?
Yeah, so this is the same thing I tell men, which is testosterone is exquisitely sensitive to stress, to sleep, lifestyle, adequate nutrition, adequate protein, weight training, resistance training. Like all of those things will matter, and you can improve your testosterone levels naturally as a woman or a man. Some supplementation, things like Tangadali, like these things are not designed, they're natural. So they are shown to work on testes in men. They haven't been as well studied in women, but there's no reason to think that they wouldn't actually benefit from a cellular level. And there's very little downside. So these are like, we can try all these things. And we have some women that are on supplements or DHEA and supplements, and they're working on lifestyle because they don't want to take testosterone, or they're worried about side effects, or they had side effects, right? And they're like, I don't want to do that. So yeah, it is possible. But you want to recheck and not just assume like, oh, this is working, because you recheck.
Yeah. So I think, yeah, the big piece when you mentioned SHBG would be managing the stress. And I've
Yeah.
read that, yeah, strength training, for example, is pretty good for just raising testosterone levels. I'm wondering now that you also have the Kaatsu bands like me, those
Yeah.
BFR blood flow
Yeah.
restriction bands. Did you read any of the research on, we know that it increases the growth hormone, but do you know of any effects that it has on testosterone?
That's a great question. I haven't seen that in research, but I have an interview coming up with individuals from Katsu, so I'm gonna probably add that to my list of questions because it seems like it would. It seems
It
like it
seems like
would.
I don't see why not. Yeah.
Mhm.
I mean, it would be interesting. I should test with the Katsu bands and without, and with my hormones and without. But that's a great experiment that I'm interested in doing. But I did get the same message that you did in terms of Katsu bands and bone health, and
Mhm.
how that there's evidently quite good studies done on that. Is there anything that stands out from this, what you read about bone health
Yeah,
and Katsu?
I'm not ready to make a final stance on that, but it is really compelling, and the literature is very compelling from a microvascular perspective, from the like milieu of metabolites that come out of doing some intermittent blood flow restriction, that there's going to be benefit from bone. So I'm super excited to kind of roll this out to my bone health group. I'm still in the research phase. So I'll do the interview, I'll do some more research, continuing to use them myself. I'm a big self-experimenter whenever possible. So this has been a kind of a fun one, and makes for some fun Instagram videos as well.
Yeah, no, I'm excited to see, yeah, see some your DEXA scan and all these things, because I've been playing around with it for a year, and I just measure with my little body composition scale, and I can see
Right.
right away when, if I'm using it, if I'm not using it, if I'm using it while I'm training or not, and I just see that percentage of muscle mass going up and down as I play around with it. So I'm pretty convinced about it, but I'm curious. I can't wait until you do the podcast, because I
Yeah,
want to see what impacts it may have on bone health after you do
yeah.
some research.
Well, I'll let you know.
Yes. Okay. So I'm going to let you go, but I would love for people to get in touch with you. The website is, I know you corrected me on the website. Which one is it now?
Yeah, so it's optimalhumanhealth.com. So
Optimumhumanhealth.com.
optimalhumanhealth.com, and then if you just look up Dr. Doug Lucas on YouTube, you'll find our YouTube channel, which is all about bone health and hormone health.
It's a great channel. It's a great YouTube channel. You give such valuable information. I absolutely love it. I'm going to have links to Instagram, YouTube, Facebook, and your websites in the show notes. And do you still have, like, during the first episode, you gave a discount code for some of your services? Is that still valid?
Probably.
Yeah.
We'll
Okay.
have
It
to figure out
was.
what it is and make sure it works. But yes, of course, whatever it
Yeah,
is, it's still valid. Yeah,
okay. It
we'll figure
was.
that out afterwards. Yeah.
Okay, great. So yeah, code Zora, Zora, and then we'll find out what that is. But if anybody wants to reach out to you and get some treated with you or your team, they can do
Yeah.
so by going to the website, right? Or
Yep. Yeah, the
anywhere
website will
else?
kind of give the description of our thing. So we have our full service program, and then we also have our HealthSpan Nation, which is sort of it's not a patient interaction, but it's a group that we have. So it's like our community, which is kind of cool. And then all kinds of free stuff. So free Bone Foundation course, free master class. So all the things that we do.
Okay, HealthSpan Nation. I'm writing this down because I don't have that in my notes, but I'll include that in the show notes too.
Yeah.
So
Zora,
wonderful.
you should be in the HealthSpan Nation, actually.
I know. I
Yeah, you should
know.
lead it probably, but it's cool. We'll talk about that later.
Awesome. Good idea. I want in. So before I let you go, do you have any last words for a woman going through the menopause transition?
Yes. So I always end every podcast that I'm interviewed on the same way, which is that you have to be an advocate for yourself. And this is so true. This was when I started this back when I was not really focusing specific on women's health and bone health. This is true for men, it's true for women, it's true for patients of all age, but especially perimenopause, postmenopausal women. You have to be an advocate for your health because so many of the paradigms and the cliches and the way doctors are trained is to keep you in a box and not give you what you need. So tell people how you feel. Your symptoms are real, and get what you need. You have to advocate for yourself because the system is not designed to support you.
Oh,
Period.
thank you so much. We need more people like you.
All right.
Wonderful. Well,
Thanks,
have a
Zora.
great day, and we'll hopefully see you next time. Take care.
Okay. Bye.